Motivational Interviewing and Quality of Life for Clients with a Substance Use Diagnosis by Mary Congrove. So the evaluation took place at New Horizons Mental Health Services, which provides several types of services to Fairfield and neighboring counties, such as psychiatry, outpatient counseling, and case management. The setting that I was practicing in was outpatient counseling. Quality of life is a factor that should be considered for anyone when considering providing care. Quality of life sets out to define the way that people are able to interact with the world so that they can have a subjective experience of positive life outcomes. When considering quality of life, the patient's perspective is the most important rating aspect, as each experience is unique even if they have shared socioeconomic or health factors. Improving quality of life is often the treatment goal for people with substance use disorders, even more so than decreasing or abstaining from the substances themselves. People with substance use disorders often have poor quality of life issues compared with the general population. Issues such as withdrawal, hazardous use, and social or interpersonal problems are a part of the diagnosis for substance use disorder, which can contribute to issues with quality of life. The National Institute on Drug Abuse stated that in 2014, of the 21.5 million people aged 12 or older who had a substance use disorder in the past year, 20.2 million were adults aged 18 or older, and over 70,000 Americans died from overdose in 2019 alone. So the issue that we're trying to address is low quality of life for people with substance use disorders. And the main evaluation question is whether using motivational interviewing influences the quality of life of people with substance use disorder. And subsequently, is motivational interviewing an effective way to engage clients in treatment? The client that's used for the evaluation is a 31-year-old male. The client voluntarily came to our diagnostic assessment with the desire to have an intake. The client reported that he suffered from alcohol use disorder and that he'd been suffering with that for about 6 years. And he was diagnosed with alcohol use disorder severe. At his initial intake, he presented as 12 hours sober and stated he was seeking treatment to overcome barriers to remain sober. So the planned intervention was using motivational interviewing. Motivational interviewing is based on several theories that have permeated social work. It incorporates the stages of change model, maintenance theory, parallelism of decision-making, Brem's balancing theory, self-perception theory, and value theory. It focuses on motivating client desires along with fostering independence and puts emphasis on the use of Socratic questioning to encourage client participation. The core principles of motivational interviewing are engaging, focusing, evoking, and planning. Motivational interviewing is directive, client-centered counseling style that elicits change behavior by helping clients explore and resolve ambivalence. Motivational interviewing is persuasive, supportive, and broad in its ability to reach audiences. It's used to elicit, clarify, and resolve ambivalence and aims to reduce denial. Motivational interviewing is both a technique and a particular style of counseling. A meta-analysis by Rubeck et al. Identified 19 randomized controlled trials which showed significant effect of motivational interviewing on several health outcomes, such as BMI, cholesterol, blood pressure, blood alcohol, and smoking. And motivational interviewing is often cited as a useful tool to help people who have substance use disorder. Considering the logic model, Some of the inputs we have are staff time, room to conduct therapy, supervisor follow-up time, WHO quality of life survey, and clients. Some of the activities are to identify clients appropriate for the program, educate client on motivational interviewing as a therapeutic intervention, deliver motivational interviewing interventions, initiate change talk. Some of the outputs are provide 5 weekly 60-minute motivational sessions to SUD clients and provide 4 sessions of motivational interviewing resources for clients. Some of our outcomes, the short, are increases self-esteem skills, increases knowledge of change, increases readiness to change, increases readiness to quit substances, and increases motivation to change. And the medium outcomes are identifying small goals, increase participation in change talk, accomplish small goals, decrease substance use, and explore ambivalence. And then our long-term outcome is to indicate increased quality of life scores. Okay, so the outcomes that were measured were quality of life scores, and where we got these quality of life scores was by using what's called the WHO quality of life brief form. So this is a survey that looks at physical health, psychological, social relationships, environment, and overall quality of life. It has clients rate these things on a scale from 1 to 5 by asking specific questions. Then you add them up to get a total score. And the WHO quality of life form is a 100 question long survey, so we use the brief form, which only has 19 questions. And the WHO quality of life brief domain scores demonstrated good discriminant validity, content validity, internal consistency, and test-retest reliability. That was from the WHO development of the World Health Organization WHO quality of brief form, made in 1998. And then a study by Wang et al. 2006 used over 13,000 adults, which had reliabilities from 0.82 to 0.86, which is actually higher than the original WHO quality 100 form, which had about 0.67 to 0.75. These were administered at the end of each session for 3 baseline sessions and 5 intervention sessions. And this was collected by the counselor and evaluator at the end of the session, and this was done at the Pickering location of New Horizons Mental Health Services. And there were no issues with the collection itself. The evaluation design is the case evaluation that is used for the project as an AV design. So this design includes providing a baseline A and then providing an intervention phase B. This design is good for seeing changes over time with the client, whether changes are positive or negative, how fast the changes, and how much the changes. The idea of this evaluation is to see changes in the client's quality of life over time as the intervention is implemented. So that's why we went with an AB design. And threats to internal validity include history, testing, instrumentation error, mortality, and interaction effects. Okay, now considering the data analysis, the visual analysis was done, and also analyzing changes in quality of life scores. So the baseline mean came out to 67.667, and the intervention, or B phase, the mean of that came out to 72, indicating that the intervention mean is higher than the baseline mean. The trend line of the visual analysis showed a downward trend on the baseline phase and an upward trend on the intervention phase. Variability showed in the baseline phase to be 1 point above the trend line and 1 point below the trend line. In the intervention phase, there are 2 points above the trend line and 1 point below the trend line. Variability shows the deviation of data points around the mean or the best fit line. This provides information on whether or not the data can predict future patterns. The data appears to have a low variability as many of the points are along or near the trend line. The total score that could have been achieved was about 95. So this data appears to have low variability as many of the points are along this trend line. Then we looked at overlap. Overlap is the percentage of data points from an intervention phase that overlaps with the range of data in the baseline phase. The number of overlapping scores is 4, showing about 50% overlap. The immediacy effect, something we measured next, which measures the magnitude of change between the last 3 data points in one phase and the first 3 points in the next phase. This shows how quickly the intervention began to have an effect or lack thereof. So here, the total range is 10. The standard deviation is 3.420004. This shows a gradual change in effect. Consistency of data patterns across similar phases are not assessed, as this is an A/B analysis. So the second set of data analysis shows statistical significance. Calculating the 2 standard deviation band provides information on the statistical significance of the data points. The 2 standard deviation band for this data is 74.09577. So considering that the highest point that's achieved is the 75, the data is not statistically significant when considering the 2 standard deviation band. The third set of data analysis shows the effect size. So effect size is used to determine the actual size of the intervention effect. So an effect size less than 70% is ineffective, while a moderately effective intervention is between 70 and 90, and then anything above 90 is considered highly effective. So the first effect size we looked at is the percentage of non-overlapping data, or PND. The PND for this data is 60%. This means that it is ineffective or questionable. The second is to calculate the percentage of exceeding the mean. This is also called the PEM. And the PEM for this data is 80%, which means the data is showed to be moderately effective. And then the third way to measure effect size is with the standard mean difference, or SMD. This is using Cohen's d to consider the means for the 2 phases and the standard deviation of all points. So with this information, we can determine whether the intervention needs to be changed, extended, or further examined. So the Cohen's d for this data is 0.07901, which is less than 0.2, which is considered a trivial effect size. So conclusions in regards to the evaluation: there was a difference in the mean scores between the mean score of the baseline and the intervention phase. The intervention phase also had an upward trend, while the initial baseline had a downward trend. The initial baseline phase was only able to get 3 points of measurement due to time constraint. The client also experienced a relapse during the baseline, which could have affected the client's baseline scores. Because there were 3 scores for baseline, and that was it, the average may have not have been effective in getting an initial idea of what the client's quality of life baseline actually was. The standard deviation showed the numbers are not statistically significant. The effect size as measured by PND and Cohen's d also showed as not significant, while the PEM showed it as moderately effective. The baseline had a 6-point range compared to the evaluation's overall range of 10, which could have affected the statistical significance. It's important to consider that the intervention itself may have not been responsible for the change in quality of life scores, as the client also began taking psychiatric medications on the third session. The client engaging in counseling in general also could have increased the scores, as counseling increases the client's social supports and sense of accomplishment. The recommendation is to continue evaluating this intervention as a tool for quality of life interventions, as client scores were highest at the end of the intervention and the PEM showed some possible effect size. Overall, the evaluation needs to be continued to better understand the intervention's effectiveness due to the overall lack in data points. Thank you.